Tokyolive Endoscopy 1.
Welcome to our session, Next Generation ESD. My name is Muhammad Ahmed. I will be the moderator of this session, and it gives me the honor to present Professor Hironori Yamamoto, who will discuss with us the safe and proper use of ProKnife with colorectal ESD. Dr. Yamamoto served as the chairman and professor of Department of Medicine, Division of Gastroenterology at Jichi Medical University in Japan. He also served as a vice president of Jichi Medical University Hospital and the director of the Endoscopy Center. Dr. Yamamoto was born and raised in Kochi, Japan. He graduated from Jichi Medical University in 1984. He then gained postgraduate clinical training in the Kochi Central Hospital from 1984 to 1986, followed by overseas training at Surgical Endoscopy Unit in Beth Israel Medical Center, New York, Department of Gastroenterology, Mayo Clinic in Rochester, Minnesota, and here at University of Texas Southwestern Medical Center in Dallas, Texas. After that, he returned to Japan to join Department of Gastroenterology, Jichi Medical University in 1995. Dr. Yamamoto has served on the boards of Japan Gastrointestinal Endoscopic Society and the Japanese Society of Gastroenterology. He also had been the associate editor of Gastrointestinal Endoscopy, the official journal of the American Society of Gastrointestinal Endoscopy from 2004 to 2009. And as one of the associate editors, I will say it is a lot of work to do this job. He had served as a deputy editor in the Chief of Digestive Endoscopy, the official journal of Japan Gastroenterological Endoscopic Society from 2013 to 2014. Dr. Yamamoto is a member of the American Gastroenterological Association. He is a fellow member, the American Society for Gastrointestinal Endoscopy, fellowship member, and the Japanese Society of Internal Medicine, Japanese Society of Gastroenterology, and Japan Gastroenterological Endoscopy Society. Everyone knows that Dr. Yamamoto also is the inventor of the double balloon endoscopy that we use in everyday practice. And he's also one of the pioneers of endoscopic submucosal dissection. He has published widely on gastrointestinal endoscopy. He was honored with the American Society for Gastrointestinal Endoscopy Crystal Award for International Service and the German Society of Gastroenterological Endoscopy Award in 2015. Thank you, Dr. Yamamoto, for all your contribution, and we're looking forward to hear from you about the safe and the proper use of ProKnife with colorectal and duodenal ESD.
Thank you. Thank you, Mohammed, for your kind introduction. I'm honored to present my talk here. Let me start my presentation. I want to share my slide. My talk is about safe and proper use of ProKnife with colorectal and duodenal ESD. Okay, this is my conflict of interest. And this is the ORISE ProKnife. And I want to explain a little bit about the features of this knife. This knife is a needle type knife with a small disc at the tip. And the diameter of the disc is 0.18 millimeter. And the diameter of the electrode itself is 0.5 millimeter. And the good feature is the injection lumen inside the needle. So we can inject solution through the knife itself. And the sheet is not big, narrow diameter. Sheath diameter is 2.2 millimeter. So it can be used with an endoscope of the working channel of 2.8 millimeters. And because of the enough space between the knife and the working channel, we can get a good suctioning function, even with the knife inside the channel. And they provide 3 types of knife. 1.5 millimeter and 2 millimeter and 3 millimeter. T-shaped electrode and small diameter electrode shaft. That is very good. And injection through the knife is possible. And this one can be used with mucoap as well. Gel fit technology. Wide injection lumen is designed to use viscous lifting agents such as mucoap. Injection through the tip is available with a syringe. So that is very good. And the cleaning tool is also available. And to clear injection lumen and restore injection in the event of a clog during long duration procedure, just insert the knife to this stylet. This is the case I will present today. This is a dysplasia in a patient with long-standing ulcerative colitis. In this case, the diagnosis is very difficult. It's difficult to recognize the extent of the lesion. This is actually a recurrent lesion after EMR in another hospital. And he was referred to my hospital, and I used indiocarmine spray, but not very sure how wide this lesion is. In this case, I took biopsy from inside and outside of the lesion, multiple biopsies. And then I determined the extent of the lesion. That is necessary. Okay, then I want to show you the procedure. Please play the video. Okay. So this is the lesion. And this is the indiocarmine spray. And I use the pocket creation method. With pocket creation method, the injection, sorry, this is too quick. Anyway, marking is placed using indiocarmine and magnification, but I used the information of the biopsy results. And the pocket creation method is started from the anal side. And after injection of the sodium hyaluronate solution, I started the incision using the pro knife. And you have to be careful not to make bleeding here. Carefully dissect. And this is the beauty of the pro knife. You can inject the mucoap through the knife itself. Right after injection and the elevation of the mucosa, then immediately after the injection, we can start dissecting the submucosa. This lesion had fibrosis because of the long-standing UC, and in addition to that, multiple biopsies I took. But using, this is the fibrosis, but using the pocket creation method, the fibrosis caused by biopsies or inflammation is not a problem. I can lift up the fibrotic tissue from the muscle layer, and even the space is narrow. Using the ST hood, the selection of the dissection plane can be precisely chosen. So in this way, I created submucosal pocket from the anal side. And sometimes I come out to the luminal side and make sure the pocket is created at the proper area. And then extend the incision and dissection and widen the submucosal pocket. after the creation of the submucosal pocket under the lesion, wide enough and long enough, then I started opening the pocket, cutting the mucosa, incision of the mucosa, and dissection of the submucosa from inside of the pocket to the outside, to the luminal side. In this way, by opening the pocket, I could finish the procedure. So mucosal incision and submucosal dissection is repeated in turn. So this is the final dissection. This is the area after the ESD, and a lot of hemorrhoid vessels, but I didn't cut it, so no bleeding procedure. This is a resected specimen, and this is the pathological results. The area of the dysplasia was correctly identified, and this was a complete resection with negative margin. Thank you. This is the first case. Mohammed, do you have any comment, or shall I continue to the next case?
Yes, so till we get the next video on, I would like to ask you about the debate of the bucket method versus traction, especially in the rectum. Traction would have worked the same. Why you would like to use the bucket method even in the rectum?
Okay, shall I answer now?
Yeah, if you,
okay.
till they have the other video.
Traction method and the pocket creation method is different, but you can use both either way. But the traction method is traction to the luminal side, one side. So if the fibrosis is severe, then the muscle is also lifted to the luminal side. But the pocket creation method can separate the specimen and muscle layer. So the traction and counter traction can be applied at the same time. And because of the narrowed tip of the ST hood, we can get a very, very good, stable condition, as you can explain when you're performing poem in the submucosal space. Endoscopic control becomes very stable. So precise control you can get. So only when the opening the pocket, it becomes unstable. In that case, we sometimes use traction using a clip and line.
Yes, and definitely this case was very fibrotic, and I saw how you did it very nicely, not even a cut in the muscle layers. This was very beautiful resection.
Thank you. Shall we move to the next case?
Yeah.
Okay, next video, please. Next one is a duodenal ESD. As you know, duodenal ESD is very challenging. The technique itself is very challenging, and complication could be very problematic. So after marking around the lesion and lifting the lesion with the mucoap, I started cutting the mucosa using the pro knife. And after mucosal incision, cutting the mucosa, duodenal elevation can be lost quickly. So even with mucoap, after the mucosal incision, the submucosal elevation can be lost quickly. So pro knife is very good because injection of the mucoap can be done through the knife itself. And right after injection, before losing the submucosal thickening, immediately you can cut. So this is very, very, very useful in the duodenum. Because if you have to change the device, then injected solution is lost, and thickening of the submucosa, it doesn't last for a long time in the duodenum. And damaging to the muscle layer in the duodenum can cause delayed perforation. Once perforation occurs, then it becomes a very serious complication. And in this case, I'm using lifting device. Duodenum is very difficult. So when I open the pocket, I combine a lifting device with the pocket creation method. In this way, I could overcome the difficulty even in the duodenum. And in the duodenum, I am dissecting, leaving some submucosal tissue on the muscle layer. That's on purpose, not right above the muscle layer. A little bit of enough submucosal tissue should be left on the muscle layer. So I dissect about the middle of the submucosa between the muscle and the specimen in the duodenum. In that way, we can protect the muscle layer of the duodenum and prevent the delayed perforation. I think the injury to the muscle layer is the most is the biggest cause of the delayed perforation. Of course, the pancreatic juice is the reason of the delayed perforation, but if you make damage to the muscle layer by the heat, then it becomes necrotic and easily make a delayed perforation. So I try not to damage the muscle layer very carefully. And using this flow knife right after the injection, and we can hook the fiber with the disc and pull back the knife a little bit and try not to touch the muscle layer and carefully dissect it. So right after the injection and hook the submucosal tissue, pull back a little bit and cut. Because the muscle layer in the duodenum is very, very thin. So it can be easily damaged and make perforation. So combination of the underwater technique and the pocket creation method and traction device and pro knife, that made the duodenal ESD possible. Thank you for your attention.
Thank you. That's a very beautiful presentation. And by the way, this is very hard to resect such half circumference in this area. I have a question, Dr. Imamura, about the knife. Was this 1.5 millimeter or 2 millimeter in the duodenal case?
Oh, that was, I think, 1.5 millimeter.
All right. And using the Pro knife, and I have used it also recently, and I noticed there is a difference between it and the other knives. Can you tell us more? What do you feel, since you're an expert using that knife? What's different about it compared to other disc-shaped knife?
Okay. The biggest difference is the injection capability. Pro knife is better than other types of the injection through the sheath type knife, like dual knife and flash knife. But I don't know about hybrid knife, because hybrid knife is not available in Japan. Hybrid knife also has an injection capability through the knife. But Pro knife, I like Pro knife because the injection is used by manual, and muco-up is also injectable through the knife. So I like using muco-up, to keep the lifting longer duration. So for my technique, this is a very good knife.
Yeah, we have noticed in the United States that although we can use this knife with a pump, when somebody inject by hand, it gives a stronger injection that's almost similar to the jet, the hybrid knife. So I agree, this exactly what we notice, especially in tough cases like this duodenal one, which is almost impossible to do large ESD like that. It seemed like it helped a lot with the injection part. So I really was intrigued by the fact that you were trying not to dissect very close to the muscle layer. And I would like to highlight that to all the audience that that's very important. I learned something new right now in that duodenal ESD. Try to go in the middle to leave some submucosa to protect the muscle layer. In your experience, what is the chances or the rate of post-ESD or delayed perforation in duodenal ESD, like percentage-wise?
Oh, not very high, using my technique, but I don't have an exact number, but I experienced a few cases of delayed perforation. But the cause of the delayed perforation is most of the time heat injury. So it was too close to the muscle layer when I dissected. That was the problem. That was the reason. So I then, since then, I try to dissect about the middle. But that is for duodenal case. In the colon and the stomach, especially in the stomach, and if there is a risk of submucosal invasion, then I try to dissect very close to the muscle layer to get a thick submucosal specimen for the exact pathological examination. So that's a balance between the risk and the benefit information of the pathological examination. So, and this duodenal case, that is a totally mucosal lesion, and I didn't think that that lesion had submucosal invasion. So the safety was more important. So I selected the middle for the dissection level.
Yeah, which is very nice, this balance between risk and benefit. Another thing, do you close these lesions routinely? This also another debate, like in the duodenum, because of the pancreatic secretion and bile juice, would you consider close this area, or it will make the lumen very narrow, so you leave it alone?
Yeah, I try to close if that is possible, I want to close all the cases, but sometimes closing is also very challenging. And if the lesion is located more distal to the papilla fata, I try to close it, all the cases, but sometimes it's not possible. In that case, I place ENPD tube to drain the pancreatic juice outside. And even without closing, as long as the dissection plane is at the middle and leaving submucosal tissue on the muscle layer enough, then I didn't explain any delayed perforation so far. But I can't guarantee it's totally safe without closing.
And just to make it more clear to the audience, you mentioned you put nasobiliary drain or nasopancreatic drain in this situation through the...
That's a pancreatic drain.
Oh, right. And for how long you leave the drain for?
About a week.
For 1 week.
1 week.
Will the patient be admitted for the 1 week or they go home?
Yes. Admitted for 1 week.
So you routinely admit all duodenal ESD for almost a week, 5 days to a week?
And that's only for duodenal ESD.
Duodenal ESD.
Yes,
okay.
And ENPD is placed. Not totally 1 week for all cases. Sometimes 4 days, 5 days. But about a week.
And do you prophylactically give them IV antibiotic?
It depends on the size and why the ESD in the colorectum. I routinely give antibiotics, and duodenal case not routinely, but when I'm high risk, then I sometimes give.
And in our experience in the United States, we have noticed in some cases, and I suspect this because we're cutting closer to the muscle layer, although the patient do not have perforation, later on they develop a retroperitoneal abscess around that area, a small one, like 1 to 2 centimeter that require antibiotic. Do you have any advice about how to avoid that? Or is it, you think it is related to the pancreatic juice because we're not draining it, or it is more post-polypectomy syndrome leading into the abscess formation?
Are you talking about the duodenal case?
Duodenal cases, yeah.
Duodenal case. Heat damage is the biggest cause, I think. And so as long as you don't use coagulation a lot and enough distance from the muscle layer, then that is the best way to avoid such kind of complications, I guess. Yeah.
All right. So an advice for everyone who's doing this procedure that duodenal ESD is the last thing to embark upon doing. And I think Professor Yamamoto showed us 2 tough cases, one at the anal canal, starting at the anal canal, and others at duodenum. A quick advice for people embarking in ESD, especially in the West, and how to start, when to embark in doing and what not to do at the beginning.
Okay, at the beginning, I advise to select a lesion with a good control of the endoscope in the rectum. The rectal case is the best, I think. Using a gastroscope rather than colonoscope, short endoscope is easier to handle, and so the rectal case is the best. And the gastric case, especially in the antrum, is also a good case to start ESD. But I guess in the Western countries, in the United States, you don't have many early gastric cancer. So I recommend you to start from the rectum.
So the rectum is the first, and esophageal, what do you think about that as an initial start for all the people who are doing EMR and the esophagus?
Mm-hmm. Yeah, esophagus, ESD is good in the esophagus as well, but I think rectum is easier and safer. And in the esophagus, if you make perforation, then that could be a serious complication. And so I recommend rectal lesion rather than esophageal lesion.
Thank you so much. This was really very impressive. I love the 2 videos, and thank you for sharing your wisdom with us. And if there's anything else you would like to add or comment before we conclude.
No, I think I can explain enough. And with your very nice moderation. I like your moderation. Thank you very much.
Thanks. Take care.